Hi there. We are going to embark on part 3 of joints. This is slide 77, so we'll start here. We will talk a little bit about some of the other joints, some details about some of the other major joints, and we will end with some discussion of pathology, of joint pathology. So last we talked about the knee joint. We honed in on that joint and talked about some details of the structure and different types of injuries. So we're going to start this one with the TMJ, which stands for the temporomandibular joint. And you've already studied this a little bit in lab. We talked about how the mandibular condyle will articulate with the mandibular fossa on the temporal bone. And so, yeah, this is called the temporo, for temporal bone, mandibular joint. Now, as far as classifying this joint, we really can say that this is considered a modified hinge joint. It does actually combine aspects of these other types of joints listed here, condylar and plane joints as well, okay? But mainly we can just call it a modified hinge joint. You should know the types of movements possible at this joint. We can do depression and elevation of the mandible, as we have previously discussed, as well as lateral excursion, which is also called gliding, and this is like a side-to-side motion. You think of this when you grind your teeth. Interestingly, this joint is the most easily dislocated joint in the body, and I'll explain why that is here in a second. Here is your temporomandibular joint. So here's the area. You remember these parts. You remember the external acoustic meatus, right? That's like your external ear canal. And then just anterior to that, you will find the mandibular fossa located on the temporal bone. And you remember that the condyle of the mandible will fit right into that mandibular fossa. So now take a look at this image here on the right. We have our mandible. And up top here on both sides, you can see the mandibular condyles. In the dotted lines, you are shown really the normal position of the mandible. And what happens when we're grinding our teeth is that you're actually doing lateral excursion, where you are moving your mandibular condyle side to side. Now the problem with this is that the actual fossa there is pretty shallow. It's shallow compared to the size of the mandibular condyle. That fossa is a little bit shallow for that, okay? So what can happen then, because that fossa is not really deep, what can happen when we do this grinding of the teeth action is that the condyle of the mandible will slip right out, okay? It will just slide right out of the fossa, okay? So that's why grinding your teeth is not a good thing. And so when this happens, you know, as you can see here, too much of this action can result in a dislocation. You can actually cause your mandibular condyle to come out of that mandibular fossa. All right, and so in essence, you are dislocating the joint when you do that. More pictures of the TMJ. All right, you know, you don't have to know all these details here, just showing you pictures. In fact, I have a lot of pictures for you for this part 3. So again, just wanting to show you different perspectives of everything. So what about TMJ dislocation? Well, as it says here, sometimes if you do like a really deep yawn or a strenuous depression of the mandible, this can also cause the condyles to come out of the fossa. Now, most commonly, the direction in which this dislocation occurs is going to be in the anterior direction. So, okay, so most commonly when you have a dislocated jaw or a dislocated TMJ joint, what you're going to see is that the condyles are moving out of the fossa in an anterior direction. So when that happens, you can imagine that the mouth, you're not able to close the mouth. All right, so anytime, like if you're working in the hospital or wherever, and you see someone come in and they have to use something like their hand to hold their mouth up to keep it closed, that might indicate to you that they may have a dislocated joint there. So what about TMJ disorders? All right, so TMJ dislocation is one thing, but a TMJ disorder is going to be something that might be a little more chronic for a person. And it does not necessarily involve a dislocation, okay? TMJ disorders are a little bit different. TMJ disorders, again, not necessarily caused or related to a dislocation. This is more related to muscles that are close to this area, all right? Muscles that have insertions or origins near this joint. Okay, so typically these are going to be muscles of mastication. Muscles of mastication are the muscles of the face and around the mandible that are going to function in chewing, all right, so eating, all right. Now, you know, some people, particularly some people with anxiety issues, you know, depending, and I'm just saying anxiety, it might be stress, okay? In some cases, a person may clench their jaw a lot, or, you know, clench, and you've seen people do that. We've all done it. But too much of this, and this does tend to happen, it's like a psychological thing, right? When you're stressed out, or if you're angry about something, or if you're having anxiety about something, then you may end up sort of clenching or contracting the muscles in your face. And you will, if you do this chronically, then you will irritate these muscles, all right? And so this can lead to what would be considered a TMJ disorder. Symptoms would be, well, the muscles in that area that you're clenching all the time are going to be sore. You will have some pain in that area of the face as well as the ear. Remember how close this joint is to the ear. It's just anterior to that. So yeah, this will typically sort of spread to the ear region. You may get popping sounds when the mouth is opened. All right, that might be because maybe our condyle is going in and out of the fossa. Okay, that could be. But again, remember, these TMJ disorders are not necessarily meaning there's a dislocation, okay? It's maybe something completely different. And typically, yeah, it is usually going to be due to irritation of some muscles, usually the mastication muscles. Also, grinding of teeth, okay, can cause this. Or poor occlusion of teeth. If maybe you had a tooth pulled or some teeth pulled and the procedure was not done in the best way, then you may have complications from that will lead to a TMJ disorder. How do you fix this? Well, stop doing this. All right? That's how you fix it. Stop grinding your teeth and stop clenching your muscles so much. All right? When you're feeling stressed out or anxiety, I don't know, try something else maybe. All right? If this is something that applies to you, if you have had this before, then you probably know what to do. And don't clench your muscles there, and you know, try to relax your facial muscles. Like it says here, relaxing the jaw muscles, your muscles around that area of the mandible. And you know, there does exist like a bite plate if this is a real serious thing. Like maybe you grind your teeth in your sleep and you don't realize it. You might be given a bite plate which will hold your teeth in that one position so that you cannot grind your teeth. Just another slide here, basically repeating what the last slide says with a few extra details. So TMJ syndrome, okay, this is something. TMJ syndrome is a type of TMJ disorder. And it's kind of an elusive little syndrome. It may affect more people than you realize, as many as it says here, 75 million Americans. What are the signs and symptoms of this? Similar to what I just described. You may hear clicking sounds. You will feel pain radiating from the joint region to the surrounding areas, like the neck, maybe the top of the shoulders, and maybe the upper back. Also, you can have facial pain, I already said. You could have headaches, vertigo, and tinnitus, okay, again, due to the close proximity of this joint to the auditory region. Then yeah, you can have some auditory effects as well, such as this ringing in the ears known as tinnitus, or you may get a dizziness, which is really related to a nerve located around the auditory region that can cause you to feel dizzy. All right. Again, what's the cause of this? Well, it may be due to tensing muscles. It may be due to a poor dental procedure when a tooth was pulled. It may be due to grinding of teeth, okay, or it can be a combination of all of these things. What's the treatment? Well, you know, if you are someone who's experiencing high levels of stress and anxiety, and maybe that's what's leading to this clenching of the muscles there, you know, maybe get some counseling or something along those lines. Physical therapy might be an option. Of course, anti-inflammatory and pain meds. Okay, if it's due to a poor dental procedure, well, obviously you'll need to find yourself a good dentist and get that straightened out. Okay, so that was the TMJ. Let's go on to the next joint. The next one is the glenohumeral joint, which you have also already had some experience with in lab. You should know the glenohumeral joint or shoulder joint is the most freely moving joint in the body. You have the highest range of motion associated with this joint. There are a greater number of movements that are possible at this joint. All right, now we'll look at some of the structures here that we find in the shoulder joint, and I'll let you know which ones you want to know. Now it says here, stability is sacrificed for freedom of movement. So yeah, like I said, this joint has the highest range of motion compared to any other joint. Now, obviously, if you're allowed to, or if you're permitted to do this much movement in that one joint, then that means there's a little bit of laxity going on in that joint. And so it's a little less stable structurally due to this freedom of movement. Kind of like what we talked about with the TMJ and how the mandibular condyle fits into a pretty shallow mandibular fossa. Kind of similar here. Think about how the glenoid fossa, remember the glenoid fossa on the scapula, how that fossa is shaped. It's not really deep. It's a large fossa, which accommodates for the head of the humerus. However, it's not very deep, all right? It's pretty shallow. Okay, so we have a little less stability for that reason as well. So some bursa, like with the knee joint, remember there were some bursae there that I asked that you know. I would like you to know a few of the bursae associated with the shoulder joint. All right, so subdeltoid. Deltoid is a muscle that you will learn later on. The deltoid is a large muscle that basically like blankets the whole shoulder area. And so we have a bursa called the subdeltoid, meaning this bursa is existing underneath the deltoid. Sub means underneath. Subacromial, so we have a bursa. I think I already mentioned this before. The subacromial bursa, all right, is just under the acromial process or the acromion of the scapula. Subcoracoid, very similar to subacromial. All right, you remember there's a coracoid process on the scapula. This bursa will exist just underneath that. And then you have a subscapular bursa. Subscapular. So this is going to be on, just sort of underneath a muscle associated with the scapula. Very importantly, part of what is going to stabilize, what stability we do have in this joint, it's important that you know what structures are associated with giving stability to this joint. And the reason these are important is because oftentimes when you have some sort of shoulder injury, many times that injury is associated with one of these stabilizers. It could be that there is damage. If there is damage, some kind of injury to anything that helps to stabilize the joint, well then, yeah, this is going to give problems, right? You're going to have a less stable joint if there's damage to any of these stabilizers. So what helps stabilize the shoulder joint? I already mentioned a tendon. Here it says biceps brachii tendon, and that's fine. You can know it as that. But technically, it's the tendon of the long head of biceps brachii. And like I said, I did mention that previously. Now, there are also some other stabilizers that I do ask that you know. These are called rotator cuff tendons. So these will be tendons that are attached to rotator cuff muscles. And I am going to mention the 4 rotator cuff muscles. You've all heard this term rotator cuff. Well, now you're going to learn what exactly is the rotator cuff. Okay, and I'll mention that on the next slide or two. The shoulder joint, hopefully you remember, is classified as a ball and socket joint. The head of the humerus does fit into the glenoid cavity of the scapula in this ball and socket fashion. Right, so as I mentioned, reinforcing or stabilizing structures that you find in the shoulder joint, you're going to have the tendon of long head of biceps brachii. This is really called the super stabilizer, because it is a large structure and it is going to play a very important role in stabilizing that shoulder joint. So you should definitely know that. The rotator cuff muscles, remember, these are muscles, I should say this differently. The tendons that attach to these muscles, all right, this is really what it's all about. There are 4 rotator cuff tendons that are really encircle the shoulder joint to help stabilize it. Definitely want to know these. Okay, these are muscles. Okay, they're also you can also refer to them as the tendons. Okay, so we have a tendon of the subscapularis muscle, and I'm going to point these out to you. We have a tendon of the supraspinatus muscle. We have a tendon of the infraspinatus muscle and a tendon of the teres minor. All right, so the tendons associated with each of these 4 muscles are going to be important in helping to stabilize the shoulder joint overall. So the glenohumeral joint, here's a little picture of it. A couple of structures we can see here. Here is the head of the humerus, and up above here we're looking at part of the acromion of the scapula, coracoid process of the scapula up here. Here's your part of your deltoid. Now the deltoid muscle is a muscle that's actually going to cover the entire shoulder here. All right, but some of it's been cut away in this image. Here you can see the subdeltoid bursa. Okay, so subdeltoid bursa, it's underneath the deltoid muscle and underneath the deltoid tendon. And I think that's all that's good for us to look at on that image. And again, I'm going to have several pictures of the shoulder joint, just, so you have different ways of looking at it. On this image, again, we see our acromion up here. We see our coracoid process of the scapula. And remember, we have our bursae here. We have a subacromial bursa right here under the acromion, right there. We have a subscapular bursa. Subscapular is actually going to be under a muscle called the subscapularis. Remember that the subscapularis is one of our 4 rotator cuff muscles. So we do have a bursa that's going to be existing under that. We have a tendon here of the subscapularis muscle. The subscapularis muscle is also a rotator cuff muscle. And I'm going to show you a couple pictures that are better as far as, showing you the 4 rotator cuffs. Here is your tendon of the long head of biceps brachii right here, and the tendon sheath that wraps around it. Again, another look at this. In green here, you're being showed the bursae, subdeltoid bursa. We have the subscapular bursa. Okay, and that's good on there, I think. Another view, okay, again, I'm just showing you multiple different views of this shoulder joint so you can look at some of these parts from different angles. All right, here is an image showing you the 4 rotator cuff muscles and kind of like how they're situated. Here is the scapula. All right, and we're looking at the lateral aspect of the scapula so that you can see the glenoid fossa. And this would be where the humeral head would articulate. So we have a supraspinatus. Supraspinatus. Why is it called this? Because remember that on the scapula there was a structure called the spine. Remember that? You can't really see it on this picture, but there is a spine on the back of the scapula. It's called the spine. Supra means above. So this is a muscle that's going to be above the spine of the scapula. So it's going to be up here. All right. We have, similar to that, we have an infraspinatus. Infra meaning below or under. Infraspinatus will be beneath or under the spine of the scapula. Okay, so supraspinatus and infraspinatus. We then have a teres minor, which is going to be on the very lateralmost aspect here, along the lateral border of your scapula. Teres minor. There is a teres major, but it is not a rotator cuff muscle. Lastly, we have the subscapularis. Subscapularis is going to be located at the anterior aspect of the scapula. Here's just another view of these. Not the best, not the most detailed here, but just so you can get an idea on sort of like where you would find these. This is a pretty good picture here from the posterior view because it does show you really well 3, or actually all 4 of them. Let's look at the one on the right here, the one on the right first. This one is the posterior view. Look at your scapula. Here is the spine of the scapula. Remember that. So below that you have a muscle called the infraspinatus. Above that spine, you have another muscle called the supraspinatus. These are 2 of your rotator cuff muscles. All the way lateral, along the lateral border of your scapula, you will find the teres minor. Teres minor. If you look on the left here, this is an anterior view of the scapula, and you can see that we have this other muscle that pretty much covers the entire anterior aspect of the scapula, and that is called the subscapularis. So you should definitely know these 4 muscles just in the sense that they are major stabilizers of the glenohumeral cavity. I'm sorry, glenohumeral joint. Here is a human being who has been dissected, and you can kind of look at some of those parts there if you'd like. Shoulder dislocation. Well, this can be pretty painful if this happens, and it can cause permanent damage depending. So here's the deal. Rotator cuff muscles protect the joint in all directions except for inferiorly. So therefore that means the most common direction in which that humerus is going to come out of the glenoid fossa would be downward. Okay, so inferior dislocations of the shoulder are the most common that you find. All right, as it says here, downward displacement of the humerus. It's the most common way that you're going to dislocate a shoulder. And yeah, you can look at these if you want. I probably won't ask you. More pictures, okay, if you just want to see a little more about those rotator cuff muscles. And that's all I'm going to say about the shoulder joint. Elbow joint. This is a hinge joint, as you remember. And at the elbow, right at that region, we have two joints that we can say exist there. A humeroulnar joint and a humeroradial joint. Easy to figure out. This is where the humerus joins up with the ulna. Specifically, it's the trochlea of the humerus that will join up with the trochlear notch of the ulna. Humeroradial, the capitulum of the humerus, will meet with the head of the radius. So all of these structures you learned or are in the process of learning in lab, so you should all know these parts anyway. All right, so those are really the two main joints that are going to make up the elbow. You have a very important bursa there called the olecranon bursa, and I'm sure you know where that is because you know your bone anatomy. You have an olecranon process on the posterior side of your ulna, and this is basically where your olecranon bursa will be. Used to be they would call, they had this syndrome called student's elbow, and this was when you would have an inflammation of the olecranon bursa due to placing a lot of pressure on that. And you can place a lot of pressure on that bursa when you're resting your elbows on a table, for example. So like if you're sitting at a desk as a student, you're sitting there and you've got your elbows like sitting on the table, and maybe you're holding your face on your hand or whatever, right? So that's why one popular term for olecranon bursitis was actually called student elbow. So at the elbow joint, again, this is mainly a hinge joint where you're going to be able to do flexion at the elbow and extension at the elbow. Now, we do have these ligaments that you learned in lab that are going to restrict side-to-side movements of your elbow joint. You have a lateral collateral ligament and a medial collateral ligament. Again, those were from lab, so hopefully those sound familiar. But these two ligaments are really going to help prevent side-to-side motion at the elbow. Now, also you have a proximal radioulnar joint. All right, so this is going to be the articulation between the radius and the ulna. All right, this one we're not joining up with the humerus. All right, but it is located proximal, so it's at the very top part of your radius and ulna. This joint can also be considered part of the elbow joint. All right, now here we do not do hinge movements, we do pivot movements. This is where we do pronation and supination. Here's a picture of your elbow joint if you want to take a look at it. Another picture of the elbow joint. And we're good for elbow. So the next joint is the hip joint or the coxal joint. Like the humerus, it's a ball and socket joint. The head of the femur will join up with the acetabulum. And you may recall from lab that the acetabulum is very deep. It is very deep. This head of the femur is pretty large, so it does need a pretty deep fossa that it can exist in, and so that's the acetabulum. Right, so this joint is going to get a lot of experience in life bearing weights. All right, so and again, it does say here, because of the deeper acetabulum, it is less prone to being dislocated. All right, so dislocated hip joint is going to be more rare. Okay, probably more likely to see something like that happen in an elderly person. All right, but before that, not very common. We do have some ligaments, of course, that are going to support the hip joint, and you did learn these in lab. There is a pretty good range of motion that you can have in the hip joint, but it is somewhat limited due to the deep socket, all right, that the femur head is sitting in. A structure you should know, it's called the acetabular labrum. This is a major stabilizer of the coxal joints. Okay, what is the acetabular labrum? It's basically a piece of fibrocartilage, which that's a really strong kind of tissue. Fibrocartilage, okay, is going to help basically reinforce the stability of the joint. It also enhances the depth of the acetabulum, and this is part of the reason why hip dislocations are really quite rare. Here's a picture of your hip joint. You've got your femur head sitting in your acetabulum. Okay, that's good. All right, so here you can see this structure called the acetabulum, or I'm sorry, the acetabular labrum. This is a human dissected, and we can see here the head of the femur. Okay, and in here is going to be your deep socket, which we call the acetabulum. And now, sort of like lining the inside of the acetabulum, you will find this acetabular labrum. Okay, and it's here. You can see it here. All right, it's going to be this real tough piece of fibrocartilage that actually is going to help keep this head of the femur locked solid inside of that acetabulum. Okay, so again, acetabular labrum is important for overall stabilization of this joint, as well as helping to prevent dislocation. Another picture of this. Here's another picture of the acetabular labrum. You can kind of see how that is, okay, in this acetabulum. Here in this picture, the femur is pulled away, as it says, retracted. The femur is pulled away, so you can see the socket there. Coxal joint with some of your ligaments. Another picture of the coxal joint in a dissected human. Remember, dislocation of at the hip joint really is rare. Where you would most likely see this would be, like I said, in an elderly person. You may see this just because there is some wearing away of the fibrocartilage that makes up the acetabular labrum. That's one reason. And in old age, you might find this. Also, well, elderly people are more prone to falls, okay, so that could be a reason. And then another situation where you might find hip dislocations a little bit more commonly would be in infants, congenital dislocation. There could be a couple of reasons for this. Remember, you're developing. The acetabulum is not deep enough yet to hold the head of the femur in place. this can happen, all right, in some newborns and infants, all right, is that if the acetabulum is not fully developed yet, then you're not going to be able to really hold that femur in place, because if the acetabulum is not fully developed, then you don't have the labrum either. You also don't have the acetabulum labrum there, because first you have to have that acetabulum, the bone, develop fully, and then you will get deposition of that cartilage, the fibrocartilage, after that. So, long story short, acetabulum is not deep enough yet, so we may see a dislocation in this case. There might be another situation where you would see this. Let's say that a newborn or a baby getting ready to be born is breech. Let's say they're coming out feet first. Well, the physicians and the nurses that are there need to be really careful in that situation, right? Dislocation at the hip joint can occur in breech births. It can occur. All right, if you're pulling out the baby from the feet, it is possible to dislocate the femur, okay, from the pelvis. All right, so those are the main situations where you would or you could find a hip dislocation. Okay, outside of those situations, it's really rare. A little bit about the ankle joint. This is called the talocrural joint. And there are two main joints that make up this joint. You have a medial joint and a lateral. You already know that the medial joint is going to be between the tibia, because the tibia is medial in the body. All right, that the tibia will join up with the talus. All right, you learned about the talus in lab. Tibia articulates with the talus at the medial side. At the lateral side, you already know the fibula is lateral on the body. So this is where the fibula is going to articulate with the talus on the other side, on the lateral aspect. And you learned about your malleoli in lab as well. The tibia has a medial malleolus. The fibula has a lateral malleolus, right? And these are the big, they seem like big bones that are kind of protruding out on both sides, either side of your ankle joint. You can feel those and see those. And these really do help stabilize the ankle joint because they help prevent side-to-side motion. There is a more restricted range of motion in this joint compared to the wrist joint. And, part of the reason for this is we have this very strong and very prominent tendon at the posterior aspect of the ankle joint. This is called the calcaneal tendon, also called the Achilles tendon. Calcaneal tendon is going to extend from the calf muscle, which we'll learn what the name of that muscle is later on. It's actually called the gastrocnemius. Well, the calcaneal tendon attaches to this gastrocnemius, and then on the other end of that calf muscle, then you will see its tendon attaching to the calcaneus, right? Okay, so this tendon, this Achilles tendon, is representing basically like the insertion, okay, the insertion of the gastrocnemius to the calcaneus. We're going to learn more about that when we talk about muscle. We'll revisit this tendon. All right, and so this tendon actually does plantar flexion of the foot. Plantar flexion. And when you're doing plantar flexion, you cannot do dorsiflexion at the same time. All right, so these tendons do that as well. They're going to allow you to do one motion while preventing its opposing motion at the same time. All right, but anyway, one reason that this ankle joint has a lower range of motion partly is due to this very stabilizing tendon called the calcaneal tendon. Sprains, of course, can occur excuse me, you know, with really any of your ligaments in the ankle, not all that uncommon. All right, it's pretty easy to twist your ankle, as they say, right? You can get sort of like a minor sprain from that. And so, you know, it just depends on the seriousness of the sprain, like, you know, on how much pain or swelling you're going to have. Here are some images of the ankle joint if you want to take a closer look at how this is. All right, so up here, the calcaneal tendon is shown right here. You can see how one end of it is attached to the calcaneus. It's cut away, all right, but normally it would be going up, all right, so its origin, where it originates, okay, is going to be up here. Here's another view of the ankle joint if you want to take a look at the human dissection. Okay, I think I did not previously record this slide, so I'm going to start over. If it did record, I apologize. You'll hear this slide a second time, but I don't think it recorded, so let me just start from the beginning. All right, so we're now talking about joint injuries and pathology. Probably a fairly common type of injury at a joint would be a cartilage tear or a sprain. And what is this caused by? Well, a number of things. There's too much pressure or compression placed on a piece of cartilage. Too much stress on the area can cause tear. You may have an open wound in the area, and you may get debris from the environment. I don't know, a piece of glass or something that goes in there and damages cartilage. Now, what's important to note here is that cartilage rarely repairs itself. Cartilage is not like epithelial tissue. Remember, epithelial tissue, you can, if you get injured, you're going to just start making new cells. Well, this is not the case with cartilage. If you do get cartilage injury, it's very unlikely that it will just repair itself. Okay, that's just not going to happen. And why is that? It's really because cartilage is avascular. Remember that whether or not a tissue repairs easily is going to be based very much on how much blood supply is there, how much blood supply is available to that region to bring all of your healing nutrients to the area. Well, cartilage is avascular. It does not really have a blood supply, and so it's not going to repair itself all by itself. If you have a cartilage injury, you will need to get arthroscopic surgery, probably. What if we have a meniscus tear? Remember our menisci in the knee. Now, you can remove part of these and still be able to move around. The joint will be less stable, but you know, you can get part of it removed and you'll be okay. If you have to have a meniscus completely removed, well, this would lead to problems, okay? But these days, typically, if you do have one completely removed, typically they're going to try to put a transplant in there, or they will take a second approach, which I'll mention in a second. But as far as a transplant, yeah, there are some really good meniscal transplants out there. They look just like a meniscus, and you just put them in there, okay? Now, as with any kind of a transplant, you always worry about the response the patient is going to have in terms of the immune system, right? So the immune system recognizes this is a foreign object, and so the immune system may start attacking the joint and causing other bad problems. All right, so that's why when you get a transplant, you are given immune suppressants in order to inhibit the immune system while you're having this transplant. All right, what's this other approach, though? I always do like to expand on this a little bit because it's really up and coming, and more surgeons are starting to use this technique. And it really means a lot to me on a personal level, because when I was working as a research researcher. I was a neuroscientist in a stem cell lab, and so I worked with all kinds of stem cells. And one kind that I worked with, these were called mesenchymal stem cells, mesenchymal, or MSCs. These are adult stem cells. And so basically, you know, I mean, I could go on about this, but let me just put it in a nutshell. So what you can do is you can extract these mesenchymal stem cells. Where do you get them from? Well, you can get them from your bone marrow. Okay, so in your bone marrow, you have a lot of these stem cells called MSCs. And what you can do is extract the stem cells from your bone marrow. And then let's say they have removed a meniscus. You had a real bad knee injury. They had to completely take a meniscus out. Well, what they can do is inject these mesenchymal stem cells. Well, I'm trying to make it a short story. I mean, there's actually a lot that will be done to those cells in a lab before they actually put them into your body. Okay, but they're going to take out your own cells, work them up in the lab and do some stuff and add some growth factors and make them geared towards turning into cartilage. And once they have that, they will take those stem cells and they will inject them into the site of injury. So they can inject them right into your knee, and then guess what's going to happen? These precious little stem cells are going to turn into real live meniscus. And this is a wonderful thing. Now this has been going on for probably 20 years, but it's just now getting to the public. And unfortunately, that's the way real science works and how real research works. You might have found a cure 20, 30 years ago for something in the lab, but yeah, like I said, it'll be 20, 30 years before anybody actually sees the treatment being applied to real people in real life. All right, so finally they are now doing this, and they're still really slow to get on board though. All right, but there are some neuroscientists in Lexington, all right, right close by to us, that are doing this. All right, they are arthroscopic surgeons who are using these mesenchymal stem cells to repair your joints. All right, this can also be done in other areas. So anyway, it's really promising though that so many people are starting to get on board with this. Hopefully we see that one day this will be offered by everybody, and that anywhere you go, you can go find this treatment. All right, so keep an eye out for that. Well, I keep trying to go to the next slide and it's not letting me. Why is it not letting me? Dislocations. You should know there is another term for this, just in case you see it. You might see this term clinically We can also call dislocations luxations. And this is just really where a bone is forced out of alignment. And it can, of course, be associated also with injury to other joint structures besides bone, right? So depending on the type of luxation and how severe it is, you can get damage to your ligaments and cartilage, to bursae, to tendons, all in that joint. So of course you will have inflammation and mobility will not be very good. How do we get luxations? Well, all kinds of different ways. Serious falls, all right, definitely in sports we can have all kinds of different dislocations possible. Subluxation is just referring to a partial dislocation. Bursitis and tendonitis, let's bring these up. Bursitis is inflammation of bursa. It can be, again, as far as causes to this, really, could be a blow, some sort of mechanical, physical blow to the area, or it could be caused by too much friction, maybe by overuse, or maybe not if overuse, but placing too much pressure on a bursa for a long period of time. There are so many different types of bursitis. I mean, it just depends on the name of the bursa. All right, so you can have a bursitis for any bursa. All right, I have only listed 2 here, so you should definitely know these names. Prepatellar bursitis. So this is involving the bursa located behind the patella. And then the second one I mentioned here was olecranon bursitis. And I just brought these up because these are pretty common types of bursitis, prepatellar and the olecranon bursitis. Prepatellar, so this would be like something you might see in someone who maybe their job involves being on their knees a lot or something like that. They actually back in the day used to call this maid's knee, because way long ago, women who worked as maids, they would be on their knees a lot because they would be on the ground scrubbing floors, right? So they spent a lot of times on their knees, and then they would get this swelling and irritation there, and that was due to placing too much pressure on that prepatellar bursa. All right, this is one of those kind of things that if you do get it, you just gotta let time pass. All right, unless it's really severe, then you'll have to get the inflammatory fluid aspirated or withdrawn, removed from the joint. Okay, but if it's not a real serious case, you can treat it with ice, all right, to help bring the swelling and the heat down. And again, if it is more severe, then you can get the fluid aspirated and get on some anti-inflammatories. Tendonitis, very similar to bursitis. This is inflammation of a tendon sheath, and this typically is going to be caused by overuse of a muscle. And, symptoms and treatment are going to be similar to bursitis. Excuse me. All right, let's talk about a couple of really important types of pathology that we're going to see at joints. Arthritis. All right, everybody's heard of this. Arthritis. That translates to inflammation of the joints. There are many different types of diseases, disorders that affect joints. Okay, many kinds. As it says here, more than 100 different types of inflammatory or degenerative diseases that damage joints. Okay, so we're only going to mention a few. We don't have time to look at all of them. We're going to go through the most popular. Okay. Arthritis is the most widespread crippling disease in the U.S. All right, meaning This is the most widespread or most common disorder that will inhibit mobility. What are the symptoms? Pain in the joints, stiff joints, swelling of the joints. For arthritis, you can have an acute form or a chronic form. Acute forms mean this is going to be for a short period of time. Most acute forms of arthritis are caused by infection from a bacterium. There are several different types of bacteria that really like to be in the joints because it's very nutritious there. All right, they love all that stuff that's in the synovial fluid. They like to feed on all that. All right, so yeah, acute form of arthritis would be typically a type of arthritis caused by bacteria because it is short term. All right, it can be treated very successfully with antibiotics and then it goes away. Chronic forms are the more common. Chronic forms, so for the long haul, all right, so this is when you have arthritis forever or for many years. Osteoarthritis is an example, rheumatoid arthritis and gouty arthritis. So we're going to go through all three of these. Let's start with osteoarthritis. Before we actually talk about this, just sort of a heads up that most students really confuse osteoarthritis with osteoporosis. Do you remember osteoporosis from chapter 7? Osteoporosis is a disease of bone tissue. Osteoarthritis is a disease of the joints, okay, not the bones, okay, not the bone part of the joints. And Alexa is talking right now, and I'm not even asking her to do so. All right, I think here she goes again.
Here's your reminder from my daily mindset skill. Don't forget to build your practice with a new affirmation. Here's your reminder from my daily mindset skill. Don't forget to build your practice with a new affirmation.
I'm sorry, guys. Let's get back to this. So, yeah, as a heads up, please keep in mind, all right, students do tend to confuse osteoarthritis with osteoporosis. Just remember, osteoporosis is a disease of bone tissue. That is when the bone tissue starts to become scant, all right? You get a thinning out of the matrix in the bone. Osteoarthritis, that is not associated with this disease. Osteoarthritis is not really about the bone as much. I mean, a little bit it is, but the pathology is associated with the structures of the joint outside of the bone, okay? Osteoarthritis is the kind of arthritis that is the most common, at least in this country and in the U.S. This is irreversible. Once you have it, it's really irreversible. This is a degenerative disorder. Anytime you see the name of a disease or disorder and it says degenerative blah, 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 or blah, 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 degeneration, we're talking about a wear and tear disease. We're talking about a disease associated with old age, all right? Anytime you see that word degenerative, that's really what's being referred to, all right, is that we're talking about a person in older age. All right, now when you're looking at like clinical scenarios and you're trying to answer questions, certain things you want to look at in the description to help lead you to the right answer. So when you're being asked about a disease and you're given the symptoms and whatnot, and you're asked, you know, what is this disease? It's really important to keep in mind the demographics, okay? In the description, you will be given information such as, is this person male or female? What is the age of the person? What do they do for a living? All right, what's their history of illness background? All right, certain information, okay, will be given in the scenario to help you come up with the answer. So a key word you can look for is this word, degenerative or degeneration, then that eliminates a lot for you right then and there. You already know then this must be one of the diseases of old age, okay? Wear and tear. Okay, so this is why it's really the most common type of arthritis. I mean, all of us are going to experience some degree of osteoarthritis. As long as we all live to see old age, we will all experience some of this to some degree. All right. Now, what are the causes? Okay, wear and tear, but there are other things that sort of contribute to this. There is a lot of research to suggest that there is a release, an increase in the release of certain enzymes that actually break down articular cartilage as we age. Okay, and so this could be a great target for treatment if we can figure out the exact enzymes and how to manipulate the activity of those enzymes. Then we might be able to treat osteoarthritis by targeting those enzymes. Okay, so more research needs to be done on that. Okay, but as a result of the release of these enzymes, the cartilage gets broken down. Cartilage starts to get broken down. Another reason we get the breakdown of cartilage is simply just due to wear and tear. All right, over time, our cartilage just sort of wears away a very small amount at a time. And cartilage does not heal. It will not replace itself. So what you end up with is, well, remember the ends of your bones are covered with hyaline cartilage. Okay, so the ends of your long bones, over time, you're going to start to lose some of that hyaline cartilage. It will start to wear away at the ends of the bones. And so then what this causes to happen is a number of things. All right, we're going to see that there will be friction, okay, between the bones when you're moving. And because there will actually be bone on bone happening here when you move, bone scratching on bone. Oh, that sounds awfully painful. It is. And so as a result of this, the bone starts to develop what are called bone spurs. Okay, and what these are just like these thickened like little points or like bumpy areas that start to develop at the ends of the long bones. Okay, this is a direct reaction of the bone responding to all this sort of like friction on it. Okay, so it's going to start to try and build bone mass, but it doesn't. It ends up hurting us. It makes it worse. Okay, so these spurs are going to really cause pain. All right, so as far as osteoarthritis, when it relates to bone, that's really the only aspect of bone really related to here. And then, of course, we're going to get the breakdown of hyaline cartilage, so the ends of our long bones will be exposed. All right, but keep in mind, this is considered a disease of joints. Okay, osteoporosis is a disease of the bone tissue itself inside of the bone. All right, age. By age 85, half of Americans will develop osteoarthritis. All right, and you should again know, age is here. You should know gender is here. It's more common in women, all right, than men. Again, this results from years of joint wear and tear. The articular cartilage or the hyaline cartilage will start to degenerate. Now, what you can end up hearing is as this disease progresses and you get more and more loss of articular cartilage, then you will start to hear something called crepitus. Crepitus is a major sign of osteoarthritis, and maybe you've heard this before. Maybe an elderly family member is sitting with you on the couch and they stand up. All right, they stand up, and when they go from a sitting to a standing position, you hear their knees crack. All right, what you're hearing is what is called crepitus. And this is literally the sound of either bone spurs rubbing up against each other, or the bone itself, all right, rubbing up against each other when they move. When they go from a flexed position up to an extended position, right, and those femoral condyles are rubbing on the top of the tibia there on the tibial condyles, then yeah, you're going to hear this sound. It's called crepitus. Okay, osteoarthritis is it's actually considered a normal part of aging, okay, because it is normal to experience wear and tear. All right, what's the treatment? Once you have osteoarthritis, you cannot reverse what damage has already been done. What you can do is help prevent it from getting worse. Okay, so one thing you can do to help with the symptoms is, do a little bit of activity, all right? Have your joints moving around a little bit, because that just increases mobility of fluid to the area to help bring in nutrients and stuff like that, to help the integrity of what you do still have there in your joints. Mild pain relievers, over the counter, capsaicin. Actually, this is part of, it's the ingredient, one of the big ingredients in peppers, like hot peppers. So if you put this on your skin, it might hurt, but I think maybe they have these creams where it doesn't hurt, but I don't know. I've never used it. I don't know anyone who's used it. But basically, this active ingredient in these red peppers has been used to treat pain, all right? And I'm not sure exactly how it works, but it has been used and been successful in treating all different types of pain. Now, when we talk about joint supplements, we see joint supplements all the time in the grocery store and in the pharmacy and everything, right? Now, the problem with this is if you do have osteoarthritis, if you start taking these joint supplements, again, it's not going to fix what has already been damaged. Okay, so it's not technically considered to be a treatment, but at the same time, you can use it to help it, prevent from getting worse. So things you want to look for in those joint supplements would be like glucosamine, chondroitin sulfate, glycosaminoglycans of other kinds, hyaluronic acid. These are the kind of things you want to look at the bottle and you want to say, are those things in there? All right, because those are what going to be, helpful for your joints. All right, but before you get to where you develop osteoarthritis, it would be a good idea, in my opinion, to take joint supplements that have these things in it, because it might help delay the onset of osteoarthritis. It might, if you still do get OA, maybe it'll make it a little less severe, all right? So I do believe in these joint supplements as preventative measurements, or preventative treatments, sorry. Okay, so that's osteoarthritis. What about rheumatoid? Rheumatoid arthritis is completely different from osteoarthritis. The reason it's completely different is partly due to the cause. All right, what is the cause of this? Well, it's due to an autoimmune situation. What does autoimmune mean? Autoimmune means that your own immune system is attacking your own tissue. There are many different types of autoimmune diseases, and just a couple of demographic facts here related to autoimmune diseases is that typically the onset of the disease is going to be in middle age or earlier. All right, this is one way you can distinguish this from a degenerative disease. A degenerative disease you will not see until later, okay, like elderly, okay, or at least over 65, right? If it's autoimmune, you know, the age is going to be different. Okay, so autoimmune, you're going to start showing symptoms of the disease much earlier. Also, autoimmune diseases, just in general, are most of them going to be more common in women compared to men. Now, men can get autoimmune diseases, but for some reason, and nobody really knows the answer to this, but yeah, for some reason, autoimmune diseases do tend to be more common in females. Again, there's really not a great amount of conclusive research to tell us why that's the case, but it is. All right, so those are a couple of demographic factors right there that can help you answer the question. All right, look at your age, look at your gender. All right, chronic inflammatory autoimmune disease with an unknown cause. The immune system will attack your own cells. Specifically, the immune system is going to the joints. It likes synovial joints. Okay, your immune system will start attacking synovial joints. And yeah, so the immune system starts attacking the synovial membrane specifically, as well as cartilage in the joint specifically. Now, once we start to get an attack on the synovial membrane, that actually stimulates the synovial membrane to make more synovial fluid, right? It's like a war going on, okay, in the joint, right? It's like a civil war going on. Your own autoimmune system is fighting your own synovial membrane, all right? And the synovial membrane is trying to fight back by making more, by trying to increase its activity and make more synovial fluid. Okay, so you're going to get fluid buildup because of this. And then, yeah, your cartilage will start to get attacked as well from this. All right, signs and symptoms. So, of course, you're going to have pain in the joints. You're going to have swelling right here, bilateral. This is underlined. And I'm underlining this because this is another thing you can use to help you figure out if someone has osteoarthritis or rheumatoid arthritis. Bilateral. So this is meaning the same joint on both sides. Rheumatoid arthritis, typically how that's going to work is the person will complain of pain in their right wrist and pain in their left wrist. Okay, so both left and right, same joint is affected. That's rheumatoid arthritis, okay? But in osteoarthritis, it's not going to be that way. They might have more pain in their right knee than they do their left. Maybe they don't have any problem in their left knee. All right, so typically in rheumatoid arthritis, the symptoms, the pains and swelling symptoms will be bilateral, whereas in osteoarthritis, it may not be bilateral. Now, other things you're going to use to help you come up with a diagnosis of rheumatoid arthritis, of course, we're going to have to look at blood. And so we're going to look and try and see if that person has anemia. All right, so anemia is a symptom of rheumatoid arthritis. And it relates to a low production of white blood cells in the bone marrow, okay, of your bone. This is also associated with the autoimmune aspect part of this. Okay, so the person may also show anemia from time to time. They may also have osteoporosis. All right, maybe we did see a person who's 80 years old and suddenly they have rheumatoid arthritis. That would be kind of rare. Okay, usually rheumatoid arthritis occurs much earlier. You're going to have muscle weakness, all right, because the tendons in these joints are compromised. You may have cardiovascular problems. Where do you most commonly see rheumatoid arthritis have its effects? The hands and the fingers, okay, so beginning from wrist going down to phalange. Any of the joints there, that's where it's most notable, all right? This is where we see rheumatoid arthritis the most. Okay, so rheumatoid arthritis begins with inflammation of the synovial membrane. We call this synovitis. Okay, so because what's happening is the immune system is attacking the synovial membrane. So the synovial membrane starts to become inflamed. It's getting damaged. It sets off an inflammatory response. Inflammatory blood cells migrate to the joint. Okay, so basically there are cells associated with responding to inflammation. They're going to travel to that joint, and they're going to start releasing inflammatory chemicals that destroy the tissue. And this is where the real damage comes in. All right, we're destroying our own tissue. Synovial fluid will start to accumulate, which will contribute to the swelling. So we're going to have inflammation, and for a couple of reasons. All right, we're having inflammation as part of the immune response, and we're having accumulation of synovial fluid, so that will cause swelling. All right, so you have sort of this double whammy there. Now, eventually, if rheumatoid arthritis is going to continue in those same joints, we just see a worsening of the situation. So if the synovial membrane continues to be inflamed chronically, then what ends up happening is that synovial membrane starts to harden. It starts to get thicker, and it hardens, and it turns into something abnormal that we don't normally have in our body. There is a term for this. It's called pannus. Okay, so basically the inflamed synovial membrane will be converted into a pannus, and this will adhere and cling really tightly to the articular cartilage. Okay, and then from that point it can just get progressively worse if this is not treated. All right, so we have our pannus. The pannus is clinging to the articular cartilage, and then what happens is that the pannus starts to erode the cartilage, okay, because it's sitting right there on top of it. It starts to wear away that cartilage. Then we're going to have an attempt by the immune system to heal the area, all right? But what we end up getting, instead of healing, because remember, joint structures really don't heal that well. Instead, we're just going to get the deposition of connective tissue that doesn't have a function there, and we get scars. All right, so we're going to have scar tissue in place of articular cartilage. And then what ends up happening, if this continues to progress, so the final stages of rheumatoid arthritis, the most severe, is going to be something known as ankylosis. This is definitely something you do not want, cannot reverse it, no way out of it. What is ankylosis? Ankylosis is actually when the ends of the bones in that joint fuse. All right, they actually fuse together, and you have zero mobility in that joint at that point. All right, so again, rheumatoid arthritis, or RA, this is actually an autoimmune attack against joints. Now, we do know something about an antibody that is called rheumatoid factor. Now, the reason this particular antibody was called rheumatoid factor, well, this antibody was not discovered and understood until after rheumatoid arthritis was known to be an actual disorder, right? So it was discovered that there were these antibodies that were coming in and attacking the joints, causing rheumatoid arthritis. Okay, so it was at that point that they said, oh, this is the antibody that's causing it. So they called this antibody rheumatoid factor. So we do know there is this antibody called rheumatoid factor that is responsible for attacking the synovial membrane. Okay, and this is not the issue with understanding this disease is that's not the only pathological That's not the only cause. That's not the only pathology behind it. There's more to it, okay? We do know rheumatoid factors involved, and we do know that there's something associated with other enzymes, okay, that are going to help, that are going to be like attacking the articular cartilage, right? And then again, eventually, if this continues to go on for a long time without treatment, then your bones will, well, you can say the joint becomes completely ossified. Basically, that whole joint is just going to be composed of bone for the most part because you have undergone ankylosis. All right. How to treat it. This RA is really tricky for how to treat it. Steroids are like pretty much a go-to for this. I mean, anybody on rheumatoid arthritis is going to be on steroids. And why is that? Because the steroids inhibit the immune response. Okay, so you will get less inflammation. Now, if you have to do this, or if a patient has to do this, they do want, if they're going to be on long-term steroids, which is really tricky and risky, but they're going to want to be careful about getting sick, right? Because the steroids are inhibiting their immune system. All right, so they're going to want to watch out and take a little extra precaution because their immune systems will be weak otherwise. All right, aspirin might be able to help control some of the pain and inflammation. Arthroplasty, so this is basically when we replace the joint structures with a prosthesis. So if it does get severe, if you do get ankylosis, then this would be a good option. So this is an individual with severe rheumatoid arthritis. They got this and they just let it go, I guess. Never got treatment, unfortunately. And actually, as far as treatment nowadays, I don't know all the exact drugs they're using right now, but I'm thinking that a lot of them are targeted directly at the immune system. And I think that some of those drugs are showing a pretty good success rate. So, we don't have to see this, right? We don't have to endure this. This individual has, you can tell that they have complete ankylosis in some areas. All right, so look at, for example, this thumb and how it's like permanently in this position. All right, this is ankylosis. This means this person cannot move their phalange. All right, they're not going to be able to move it. The bones are completely fused there. You can see the extreme swelling in the joints as well. Another severe case of rheumatoid arthritis. Again, it's pretty severe if it looks like their hands are just stuck in this position. It's because they are. You can see from the image down here that where these areas are that are really dark, this is where we have ankylosis. That means the bones have completely fused together. All right, we've got a lot of issues going on there. All right, be sure that you can tell the difference between osteoarthritis and rheumatoid arthritis. And remember not to confuse osteoarthritis with osteoporosis. And we're going to wrap up here pretty quickly with a couple more diseases here, and then we'll be done with this chapter. All right, another type of arthritis is called gouty arthritis. What is gouty arthritis? This is when you get arthritis due to deposition of uric acid crystals in the joints. Uric acid. Okay, so we get a buildup or a collection of crystallized uric acid in the joints. What is uric acid? Uric acid is a breakdown product of the protein that you consume. All right, so typically we're going to excrete that. Okay, uric acid is typically something that we don't hold on to. It's a waste product. Now, if you're a person who has a high protein diet, let's say you eat steak like every day, right? You are more prone to develop something like this because if you're having too much protein, remember, too much of a good thing is never a good thing. So too much meat or too much protein, you might not be able to excrete all that extra uric acid. So what happens is that uric acid will get stored somewhere else. It likes to go to the great toe. All right. You know, lots of reasons for this. All right. So if you've got uric acid floating around in your venous system, that uric acid, if it gets crystallized, right, is going to be sort of heavy, and it is not going to go against gravity. It is going to stay there in the feet, and then it's just not going to circulate at all. All right, so it'll stay and end up in the big toe. All right, what does this look like? You may know someone who's had this or seen this before, but the big toe is going to look red, and in some cases might look dark, but it's going to look bad. Like, it'll look real swollen, and it's just that big toe. All right, this is gout. This is gout. And so as a result of gout, okay, since we're dealing with joints, we can get gouty arthritis. If this is not treated, you can end up getting ankylosis. You can get your little bones down there to end up fusing together, and you will no longer be able to move that joint. This is more common in men, all right? And I think that is just because men may have a greater tendency to consume higher amounts of protein. All right, that could be in men that maybe work out a lot, I don't know, or men that don't necessarily work out a lot and they just eat a lot. They eat a lot of protein and they don't get any exercise. That's really where you're probably going to see this more commonly. How do you treat it? Water, water, water. Most of the time, if you're diagnosed with this, you go in, the physician's going to be like, drink, like, I don't know, 20 glasses of water a day. I don't know what number, but it's a lot, okay? Just drink a lot of water and it'll start clearing this up. There are certain drugs that you can take. You want to avoid foods that are high in protein. Obviously, if you're having this, that's because you're having too much protein, right? So cut some of that out. Foods like liver, kidneys, sardines, these are high in protein, okay? And alcohol, just, avoid alcohol, because alcohol does not help us to clear out the system very well, all right? Alcohol ends up dehydrating you. It's not going to help you get rid of stuff. It'll help you hold on to stuff. Lyme disease, I think this is the last disease here. This one, well, this is actually caused by a tick bite. Okay, there's a certain bacteria, there's actually a few different types of bacterium that are transmitted by deers, for example. Ticks, right? Ticks that bite deers that have this, all right, can transfer that to humans if that same tick goes on a human. So it causes joint pain and arthritis. Now, how do you distinguish between the different joint diseases we talked about? Because all of them are associated with joint pain. Okay, with all of them, joints are going to be hurting. You may see swelling. You may see redness, right? How do you tell the difference? Well, you need to know things about the person's lifestyle. You need to know things about, like, what's their age, what's their gender, all that. And, like, what have you been doing the last week? Have you been out in the woods? Have you been hunting? What have you been doing where maybe this person was exposed to a tick? You can also eliminate osteoarthritis and rheumatoid arthritis if the person has a fever. right? Because this is a bacterium. So you may have a fever, all right? So if a person is presenting with flu-like symptoms, if they have a fever, and if they have a rash in the area of the joint, okay, these things are all going to help you eliminate any other type of arthritis. All right? Lyme disease. If you do get Lyme disease, it pretty much sucks. There is a long course of antibiotics. All right? This is a tough little bug, bacteria living in these ticks. It's a very tough one to combat. And yeah, so you're going to be given a long course of a wide variety of antibiotics, and you have to take like specific antibiotics for a specific number of days and then overlap some of them, and it's actually a pretty strenuous regimen of antibiotics, and you'll have to do that for quite some time. All right, so just summarizing joints, right, and talking about developmental aspects of joints. Joint size, shape, flexibility are all going to change over time, okay, due to use. Again, remember, we're like classic cars, right? Okay, my 1977 Corvette in 1977 ran beautiful, but now I have to do a lot of work on that car to keep it running beautiful, right? So we're like that. We're like an old car engine. With use, there is wear and tear, and you start to see a decline in function everywhere in the body. All right, ligaments and tendons will start to shorten and weaken over time, okay? As we advance in age, we don't really tend to move around as much. And so this actually affects the laxity and the tautness of the ligaments and tendons, all right? The more active you are as you age, well, the more mobile you're going to be as a result, right? So if you stay mobile, you're just going to keep these structures more healthy over time. They're not going to like tighten up so much. Movement will be easier. Now, also something that's very common with age at a specific joint, and these would be the joints between the vertebrae. Okay, so intervertebral discs are much more likely to herniate with age. What does that mean, herniate? Well, basically, in between your intervertebral discs, remember that let me start over with that. Remember that in between your individual vertebrae, you have these little fibrocartilage discs. These are called intervertebral discs. Now, inside of those intervertebral discs, there's actually a fluid. I believe it's called fibrosa pulposa, something like that. That fluid, okay, can end up seeping out of the disc. Over time, just with continued pressure on your lower back, for example, after many years of carrying around your own weight, you may get this situation, all right, where the intervertebral disc starts to seep out the fluid, and then that decreases the size of the intervertebral disc, and then you have your vertebrae real close together, and you have basically like a form of arthritis there as a result of that. And again, most people in their 70s are going to have some level of osteoarthrosis. All of us are going to see some degree of this. Severity just depends on your lifestyle and nutrition and other factors like that. It says here, full range of motion exercise is a key to postponing joint problems. And yeah, that's true. You want to keep your ligaments and your tendons mobile, all right? And practice your full range of motion exercises to keep those joints healthy. This last page just showing you some pictures of some prosthetics that are used. Here would be like a knee replacement. Here's another one down here. You can see how the condyles, these look just like condyles, right? Just like condyles of the femur. And those are going to fit right into these prosthetic menisci that are sitting on the tibia there. Yeah, so that would be a knee replacement. All right, here's a hip replacement. And And that looks really simple mechanically, and it is. Most of your hip replacements, not a problem to do, really. I mean, because we've got this perfect little way to fix it like this. You have an artificial acetabulum, and then you have an artificial femoral head. Fit it in there. There you go. All right. Now, of course, the person is going to have some issues with healing. That will take a while. All right. But generally, these hip replacements are pretty successful. But keep in mind, nowadays, we're really starting to go that stem cell route. I predict that one day we will not even be using prosthetics. I predict that one day we're going to be using stem cells, all right, to regrow your own menisci back, all right? That's all I have for you for joints. I hope you have a great day, and talk to you later. Bye.